A very interesting case. This is a nice lady who had left breast cancer and in 2021 had reconstruction with implants. And then she ended up getting capsular contracture. In 2023, she got her second surgery and then she got her second set that was placed. And as you can see, she got the capsular contracture. Again, see how round and raised this is compared to this is more flat. This cream part is consistent with the Alloderm, which is cadaveric skin that was used. So capsular contracture, this is 100% total capsulectomy. Overall, I'm very happy and content with how the whole dissection has gone. And I'm very, all of the inflamed tissue, capsular tissue has been removed. The other thing I want to point out, this is the excess skin that I removed for the dog ear. You can see the nipple sparing mastectomy she had. This is her nipple. So for oncologic cancer reasons, this right mastectomy scar is going to be sent. It's tagged at 12 o'clock for orientation. So we know this is medial, this is lateral. And if I pull this up, you can see there's breast tissue about. And so we're going to go ahead and check and make sure she does not have breast cancer. Just given her history along with other abnormal pathology. So I'm going to go in from here, from this back part, if you will. Let me go in from here, the Alloderm boundary. And so we'll see. All right, I was able to, you can see how thin this is. I'm going to slide the instrument. But when I go like this, you can see how thick this is because this is cadaveric skin. And as I go in with my scissors, I'm going to cut right at the boundary and you will be able to see. Now it's very hard. And you can see, look at this. So this is where it's being meshed. And this is the skin from another person that was cleaned out. And look how it's bunched up together, right? And again, look at this Alloderm. All of that has been removed. And you can see, so on the back there is what I would say mild amount of fluid. All of this contained, none of this spilled. You can see it's not as sticky, but definitely some fluid. All of it was contained. Not enough to send. So this is 350 Mentor. You can see the fluid remnants here. I'm going to put it right here. And then you will see what are patches of this cadaveric skin, the Alloderm used in reconstruction, this yellow. And overall, I'm very happy. All inflamed tissue has been removed. If I touch it, it's a little bit thick. You can see like a 1/2 centimeter thick. And all of this bad tissue has been removed. Everything contained, all the Alloderm removed. And again, you will see right here what appears to be a meshed Alloderm so that it can spread out. So there you have it. Complete total capsulectomy, 100%, along with Alloderm, all inflamed tissue, scar tissue. The initial capsule and then the secondary capsule, and that what makes it thick. This is the end block, 100% total capsulectomy. I just want to show you here, this is the cancer side. You can see the skin, this is the skin, the Puda orange appearance of the skin. Right here, these are the hair follicles. So if I flip this around, you can see how thin this flap is. So this is just the dermis. This is the skin only, minimal fatty tissue. All the way, this is the 12 o'clock position. This is the cancer side. Remember, the nipple areola is native original. So this will be sent to pathology. They're going to go ahead and analyze the breast tissue behind because they leave a small cusp of it behind. Given the history of left breast cancer, this is medial, lateral for the dog ear contouring on the lateral side such that she has a flat chest aesthetic closure. And as you will see right here, complete implant capsule. The fascia of the pectoralis major was also removed. And you can see a small band forming here. Let me go in from here. I'm going to go ahead and just bunch this together. This helps. Because now I know it's away. Intact implant. Remember, these implants are just 2 years old. So as I go in right here, I'm cutting through the Alloderm, and you can see right here, it's very thick. And block the gold standard. And again, some fluid in the back. Mentor 350 as well. Brand new condition. If I just put this here, you can see the yellow. And you can see the regular capsule. You can see the patches off. You can see how thin the capsule is. No matter how thin, the entirety of it is removed and end block, along with the very, very thick. If I try to tear it, I cannot. And even if I try to cut it, you can see that's why it's used in reconstruction. It's extremely thick. And so this will be going to pathology. So, yeah. Question here is the orange peel skin indicative of anything regarding cancer? So the bottom line here is this. I cannot tell from looking at it what it is and what it is not. Ultimately, the only person who can is the pathologist, the MD, who's going to stain it and who's going to process it and look at it under the slide. And with the appropriate staining, they're going to make sure it's breast cancer or not. So what this yellow is classically, we have seen this many times, Alloderm cadaveric skin. They'll process it and take representative samples and then look at it under the microscope. For CD30 analysis, CD30 analysis is a special stain marker to look for that rare BIALCL. If you don't do the CD30 stain, you're not going to be able to definitively rule out the BIALCL, which I mandate my pathologist to do because I have had a verbal and a direct communication with them on email that I must and I demand, even if the insurances say it's overkill, till we have done the CD30 analysis, we will know what we're dealing with. And we don't want to miss the BIALCL. And that's why, as you will see, in the vast majority of the cases, the capsules are not completely removed. And even when they're removed, they're not sent to pathology. And even when they're sent to pathology, the surgeon does not tell the pathologist to do a CD30 stain, and that's why it's underreported. And this is a well-established fact. It is now relatively very rare. To date, only 1,300 cases of BILCL all over the world in the history of the world. But we know clearly as surgeons that this is underreported because not many people, if at all, are even checking for that rare BILCL. So the implants will be returned to the patient. This is the con procedure. Number 2, flat chest aesthetic closure. The cultures will be done for Arabic, anaerobic, and fungal. The capsules will be sent to pathology separately, right and left, including the Alloderm, where they are going to process the sample, make sure it's not breast cancer, it's not the BILCL, and BIASCC, which is the breast implant-associated squamous cell cancer. Anything and everything bad was incorporated along with the capsule, the tissue around, including the inflamed tissue that was also removed, and that will be sent to pathology. The no need for drains, twilight deep sedation. She has high definition pictures, videos, as you can see, of this, but more importantly of the chest wall, showing complete removal of the entire implant capsule. Now the right and left mastectomy scars also will be sent, so that we can look behind, make sure there is no breast cancer around the ducts. She had DCIS, which is ductal carcinoma in situ, so they're going to go ahead and assess the breast tissue, that small cusp that is behind, to make sure that she has no possibility of having what is breast cancer. And then we will have the peace of mind when we get that feedback back from the pathologist that everything is good and there will be no surprises awaiting us. So anytime anything is removed grossly, no one can tell by looking at it. I cannot tell what is cancer or not. Only when the pathologist looks at it and stains it and looks at it under the microscope and the final pathology result comes back, only then do we know with definitive certainty what it is and what it is not. So hopefully you found this informative. Anything foreign is removed, including Alloderm. I didn't see any permanent suture. The surgeon who did this surgery was an excellent, very seasoned surgeon, and it shows as I do the removal how it made my job easier. The other thing I want to say is someone gets capsular contracture once, let's say on this case, the right side, almost always you end up getting capsular contracture again. Less chance of capsular contracture if it was below the muscle than above. And again, capsular contracture, why it occurs, majority of the times we do not know. This is Dr. Khan, Executive Plastic Surgery.